Welcome to Advanced Case-Based Strategies to Integrate Recent Progress in the Management of PsA. Joe Morrell and I are delighted to be here with you this afternoon to go over basic aspects about psoriatic arthritis and its pathogenesis, clinical presentation, and treatment, as well as illustrating a lot of those points by discussing some pretty interesting cases with you and some challenges in terms of treatment approaches. This is an activity provided in collaboration with Rush University Medical Center and Practice Point Communications, and it's supported by an independent education grant from Janssen and Novartis. I am Philip Meese. I'm Director of Rheumatology Research at Swedish Medical Center, which is part of the Providence St. Joseph Health System on the western part of the U.S., or you might say the left part of the U.S., and clinical professor at the University of Washington in Seattle. My disclosures are below. These are predominantly related to consulting that I do about the trial design for PsA studies and the conduct of them, and ultimately publication of them, and presentation and education about them. And I'm joined here today by an esteemed colleague, Joe Morrell, who he's in his usual very modest style. He won't be shouting all of his different accolades, but he's unique in that he's doubly boarded in rheumatology and dermatology. So to be quite honest, I don't even need to be here today. He could just run with the whole show. But Joe, tell us about yourself.
Philip, it is my honor to be with you on this. By all means, I'm Joe Morrell, dermatologist, rheumatologist, as Philip mentioned, here in Boston. Ironically, I'm also in the left part of the country, Philip. I'm in Massachusetts, so I'm thrilled to be here. Very much looking forward to sharing and learning from you and spending some time together this evening.
Great. Here are our learning objectives. We're going to be going over the heterogeneous aspects of psoriatic arthritis, and then touching down on the significant burden represented by the disease. We're going to talk about both current and emerging therapies for the disease, and then focus in on a multidisciplinary approach to treatment in which dermatologists and rheumatologists work closely together, as well as the rest of the village that takes care of psoriatic arthritis patients. So let's get going with thinking about PsA. PsA is a condition which occurs in about 6 patients or 6 people per 100,000 population per year in the United States. It's not a common disease. If we look over at psoriasis patients, however, roughly 24%, a quarter of patients at least, who have psoriasis will at some point in their life have evidence of psoriatic arthritis. It could be a persistent, ongoing polyarticular synovitis with enthesitis and spondylitis and so on that significantly impacts the patient, or it could be a lesser presentation with, just say, episodic arthritis or episodic enthesitis, and so on. Its highest prevalence is among people from 30 to 60 years of age, and we see more of it in North America and Europe than in some other parts of the world, such as Asia or Africa. This gets across the point that there's a significant disease burden, both at a physical level, a psychological level, and social level, with impacts on not only on pain and physical function, but also the prominent comorbidities of depression, anxiety, and just being embarrassed about having this problematic skin disease. And then social impact on ability to work, ability to participate in family life, and so on. Joe, if you don't mind, you've been highly involved in this work that is displayed on this slide, and I appreciate it if you would run with this.
Sure, I'm happy to. And it's really interesting to think about, and it's pretty unique, among many of our disorders, to think about an at-risk, or pre-disease state, right? To take a step back, we know that something upwards of 75 to 80 or even 85% of our patients with psoriasis or psoriatic disease rather have psoriasis before they have psoriatic arthritis. I'm in the camp that I think probably that number is even a bit higher if we as rheumatologists were seeing the seronegative inflammatory arthritis patient and really getting them undressed and looking for hints of psoriasis in the scalp and inverse or intertriginous areas. And we'll come to that, I think, as we get into some of our cases. But that said, again, the vast majority of our patients have skin disease before they have joint disease. And so for that reason, it's interesting to look at this psoriatic arthritis continuum. So why is that unique? It's unique in that we have this sort of pre-disease state, if you will. We have patients who have skin under nail psoriasis. And although I would say this is not terribly well worked out, we certainly know there are a number of factors that put patients at higher risk for going on to develop psoriatic arthritis in that population. Some of them are listed here, including phenotypic subsets of skin disease, scalp disease, inverse or intertriginous disease, nail disease. And then there are a variety of other factors, obesity, certainly genetic risk factors and others that put them at a higher risk for going through this, moving to the right on this diagram. Then at some point we think of patients potentially in a preclinical immune activation phase. This is where patients really have subclinical disease, but presumably there is an immunologic event happening that's getting them prepared potentially to develop synovial enthesial inflammation. You then look to the right of that, and we see patients developing. They may still remain subclinical, but now have findings perhaps on imaging, or they're moving into a sort of achy phase, if you will. They're developing arthralgia, maybe some mild stiffness, sort of moving from this preclinical into a clinical phase, and then ultimately some number of them going on to develop what we would consider diagnosable psoriatic arthritis. So there is a continuum. I think this is an area of active interest scientifically, immunologically. It's also an area of interest for many of us because it supposes perhaps that we may even be able to intervene somewhere in this flow diagram and potentially stop the disease a bit earlier in its tracks, maybe even if we're a little aspirational, prevent the development of psoriatic arthritis among that at-risk skin population. So, and
oops, I moved to
I think we may have covered many of these. I won't belabor it, but just to say that I think we know we have a reasonable understanding of the genetic risk factors that may underlie psoriasis. We have reasonable amount of data around genetic risk factors that predispose to psoriatic arthritis, or at least are associated with psoriatic arthritis. There's some overlap in those areas, but not entirely. I think we understand much less about the potential environmental factors that might lead to the development of psoriatic arthritis in that psoriasis population. And as I mentioned, there are some phenotypes of psoriasis patients that make us think about a higher risk population, with nail probably being one of the most well established and recognizable. But again, a few of the other phenotypes I mentioned, scalp and inverse or intertriginous disease.
Thanks to the efforts of people like Oliver Fitzgerald and Bob Winchester, who is at Columbia and Oliver's in Dublin, they did some seminal work having to do with establishing the genotype of patients that evolved into having a particular type of phenotype of psoriatic arthritis. So we know that there are certain genes that lead to a more axial and enthesial predominant form of the disease. There are others that emphasize the cutaneous expression of the disease, and other genetic phenotypes that lead to synovial or arthritic predominant. So one of the things that I will say to each psoriatic arthritis patient that I encounter is that your disease is going to be like no other. You're unique in terms of the expression of it, and that is indeed the case. The other thing that I like to sometimes do is just bring up in people's minds the idea of an orchestra, that sometimes there's many different sections of the orchestra playing: the arthritis, the skin disease, the enthesitis, and so on. And then at other times, it just may be like a patient I saw today earlier who was really well controlled with most of their disease aspects, but it was her Achilles tendon, which was really disabling her over the last 3 months. And so that is something that we have to think about and either treat it locally and regionally, or think about switching systemic disease treatments. One of the things that's shown here is what are some of the key features that distinguish PsA from other diseases that are commonly seen in rheumatology practices, including rheumatoid arthritis, ankylosing spondylitis, and osteoarthritis. And here's a color coding system, which is overall probably pretty accurate, but it makes the point that we're treating a different disease than RA, and a different disease than AS or OA, and we should be focusing in on what are the symptoms or signs that are teaching us that they've got skin and nail involvement, and it behooves rheumatologists to do what dermatologists do, which is to get the patient to come in and undress and look in different places. Joe, how do you handle it with a PsA patient in that regard? And you're much more comfortable with that as a dermatologist doing that.
Yeah, it's a wonderful point, Phil. By the way, I love your symphony analogy. That's I've stolen that one for talks in the past. I think it's a very apt analogy. It's a nice one. And Philip's a wonderful musician, which is where I think that comes from. It's interesting, I was in the dermatology office earlier today, and it's so commonplace for us to have patients, and they expect it to come in and, have our staff really ask patients to be undressed to their comfort and in a gown open to the back. And it really facilitates a lot of what we do, especially in the psoriatic patient, where we have a deep look through, the scalp, not just classical extensor areas, but in inverse intertriginous areas behind the ears, in the axilla, in body folds, in inguinal folds, intergluteal cleft, all the places that really, psoriasis likes to hide. And I think that is relevant for us, in rheumatology, in the one hand, as you raise, for the patient where you have a suspicion that they have a seronegative inflammatory arthritis, they have an oligoarticular or other pattern, it's awfully nice to find that plaque of psoriasis, right, to help sort of seal the diagnosis, the nail pits, or perhaps a gluteal cleft plaque or something that really gives you that confidence, and changes the pretest probability, I think, of what you're dealing with. So I agree. It's wonderful to have patients undressed, and we don't do it as frequently, certainly in the rheumatology clinic. The other flip side of that, which we'll come to in one of our cases a little bit later, we know that the burden of disease for patients with psoriasis is high, and that includes areas of special interest, right? That includes body fold areas, genital skin. So even if we're not comfortable getting patients completely undressed to look in those areas, I do think we have to ask about involvement in those areas so that we're getting patients, appropriately treated and to the point of where they'd like to be with their therapy. So sorry for the long-winded answer, but
no problem. The other issue here that's sort of a black box is axial spondyloarthritis, and we're going to come to that in one of our cases. But it raises the challenge that when we are with a patient who's in their 40s or 50s, for example, and they have had several sets of lumbar films that show degenerative changes, and the orthopedist or the primary care doc has pointed to that and said, well, this is just inflammatory arthritis. Degenerative arthritis, then it behooves us to look more carefully, to consider MRI scanning, to look at the sacroiliac joints, to do a few things to try to ascertain whether or not they may have axial inflammatory involvement. But we'll get more into that. And then there are also important comorbidities that are noted here. And this is, again, where it takes a village. So we really depend upon the patient's involvement with their primary care doc, their cardiologist, and others to help manage and control these comorbidities that are partly genetically driven. And so even though the patient may really have a strong goal of being lean, of controlling their cholesterol and so forth, they're swimming upstream because they have a genetic proclivity for these problems more so than the normal individual. And so they have to really work at it. And one of the things that we have found is that in studies where there's significant weight loss, for example, planned weight loss, that the patient can improve and have better outcomes from a musculoskeletal point of view. And so this is one of the things that they can do for themselves. And we're going to get to talking about some of the other issues here in a moment. Joe, you want to take over on talking about some of the graft treatment recommendations here?
Sure, absolutely. I'm happy to. So, I would overarchingly summarize this slide as thinking about maybe three big filters through which we think about approaching treatment in discussion with our patients with psoriatic disease, with psoriatic arthritis. And, the GRAPPA framework has really revolutionized, I think, the way we think about the approach to our psoriatic disease patients, namely in a domain-based way. We're going to come to that in just a few slides as well in a little more detail. But the three big filters I think about, my interpretation may deviate slightly from what you see, but I think the first filter is looking at which are the predominant domains of involvement, for the patient sitting in front of me, right? And those are based on the domains that we'll unpack in a few slides, followed by a consideration of comorbidities. And I think about that on two levels. So one is with regard to comorbidities, which therapy is compatible with a given comorbidity, meaning, it won't exacerbate it or make it worse, and or potentially which will in fact synergize to help treat that comorbidity potentially. So that's sort of my second filter. The third filter to me is the the shared decision making piece about what is the patient's preference, what are their goals for therapy, and thinking about the unfortunate fourth filter, which is, at least in the United States, what access do I have? What can I actually get for the patient, right? But you see those more or less in the figure on the right, thinking about choice of therapy by domain, considering comorbidities, and then thinking about sort of a reevaluation by treatment goals, whether that's a formal treat to target or at least minimally a discussion with patients about in a shared making way about where they want to be with their therapy and what their goals are for treatment. Thank you. And
so here we are with the various pharmacotherapy options, starting with a simple treatment such as nonsteroidals, hopefully only limited steroids if you use them at all. And then conventional synthetic DMARDs, which is prior to the biologic area dominated, including methotrexate as the key agent that we've used. And then since the early 2000s, really our treatment approach has been revolutionized by the increasing number of biologic agents targeting TNF, IL-12, 23, IL-17, IL-23, and then the T-cell modulator. And then more recently, the oral agents, the PDE4 inhibitor, Primilast, and JAK inhibitors. So we've gotten, especially in the last decade, a broadening array of medications that we can choose from. So let's go, we're going to talk about show you some domain-based recommendations in a moment, but keeping in mind that what we're trying to do ultimately is to treat to a target of either remission or low disease activity. And the one that the goal that we use most in the clinic is something called minimal disease activity criteria. We'll speak about that more in a moment. And find that really is correlated with the patient achieving great goals in the long run, like structural damage inhibition. These are some of the measures that we use in clinical trials. We're not going to go through this in any detail, but just to say that this whole field has evolved significantly since the late 90s, when I first got involved in designing PsA trials, and really we had very little to go on in the way of precedent for what measures to use. And so I borrowed an ACR response from some of the RA trials and looked at this complicated scoring system called the PsA scoring system that was developed by this obsessive compulsive Swede guy in which he measured quantitatively the skin, and that was it. I didn't even know to think about designing trials to measure enthesitis and so forth. But we really gotten a lot better about getting at what's important for patients, including skin, nails, all the musculoskeletal domains, including enthesitis, spondylitis, but also important domains for the patient. Fatigue standing out as one of them, this cytokine-induced fatigue that just floors patients and makes them need to just go lie down in the late afternoon, and really affects them at work, for example. And the fact that many of our drugs can improve this has really been an advance. I'll comment on the peripheral on this page that in the peripheral arthritis, most of the drugs that we've just walked through are effective in treating peripheral arthritis. Maybe a little bit less so with some of the agents such as nonsteroidals that are mentioned here, and really nothing to recommend against. If we move to axial disease, then it becomes a little bit more complicated. And for most of these agents, we have used trials of ankylosing spondylitis with the drugs and use that as a surrogate for, okay, this will work in axial PsA. And for the most part, that's worked out okay. So we have ankylosing spondylitis trials with TNF inhibitors, IL-17, and JAK inhibitors, all of which show good effect in those diseases. The only drug that has been actually tested thus far in axial component of PsA, which occurs in about 40% of patients, is the IL-17 inhibitor secukinumab. They mounted a focused trial on axial PsA and demonstrated benefit. And in a moment, again, we'll show you some of the more controversial data, and what not shown on this slide, but there is a category in the GRAPPA guidelines known as not enough data, and that's for the IL-23 inhibitors, because they failed in ankylosing spondylitis, but may be beneficial in axial PsA, and we're in the midst of trying to determine that. Joe, do you want to comment on enthesitis and dactylitis?
Sure, Matt. So here you can see as well, the consideration for one of the GRAPPA domains of enthesitis, and following some of the grade-like methodology here around strength of evidence based on pretty robust literature review for these updated guidelines. You can appreciate the various classes here that have data to support use in patients who have enthesitis as a part of their disease and as a predominant domain of their disease. You'll appreciate here TNF inhibitors, IL-12, 23, 17, 23 inhibitors, JAK inhibitors, PDE4 listed. And then you can appreciate some of the conditional recommendations as well. I think, as we synthesize some of these over cases, I think this will start to come together a little bit more nicely in our understanding of how we apply these. And here you see the dactylitis data similarly. So following that same methodology for the updated GRAPPA treatment recommendations, you'll see a lot of those same players here for dactylitis under the strong recommendation category, as similarly for conditional. I think one of the, Philip already touched upon this, but one of the key domains where you see a bit of a deviation is in that axial compartment that was already covered. You'll similarly see as we go through this, some of the comorbidities also impact strongly our ability to use different mechanisms in this arena. And if I may, Philip, I'll take this psoriasis one as well.
I'm sorry.
That's okay. So this one is a tricky one, and in fact, we could probably spend a lot of time here. I won't bore everyone, but this has a lot to do with the context in which these guidelines were, or treatment recommendations rather, were evaluated. And so we're really thinking here about level of evidence, mostly drawn from psoriatic arthritis studies, in thinking about how we apply strength of recommendation around for some of these psoriasis therapies, but as well, you'll see included a number of therapies that are not facing PsA or PsA patients. So, when we think about this at high level, it has a lot to do with the severity of the underlying psoriasis. Is it more mild or moderate to severe skin disease? That may help us decide, how are we treating the other domains of PsA. And so if you look, for example, under the plaque category for options such as topical and phototherapy, naturally those would be facing those are skin-directed therapies that could be added to ongoing PsA therapy, or would be relevant to the patient with skin-limited disease. And in that category, in fact, even in the last few months, there have been advances in our ability to think about the breadth of options for topicals. We have some new approvals and such in that area that are helping us, broaden the options for our patients. We certainly still think about phototherapy, and then we'll go through this in more detail. But you may ask, well, how do I decide among these multiple options? And I make many of my rheumatology colleagues jealous with the number of head-to-head studies we have in psoriasis with many of these systemic agents. And so I think we do have some data that we'll share together around, thinking about the patient with more, skin predominant disease, or more, moderate to severe skin disease, and how we approach that based on the data and head-to-head data. Nail disease is interesting. I would say as an overarching theme, those drugs that are highly effective for plaque psoriasis are often also our most effective nail therapies. And so you'll see a lot of the same mechanisms here. Certainly some of our most effective nail treatments include some of our newer highly effective skin-directed therapies such as IL-23 and IL-17. You'll also see some conditional recommendations for localized therapy there. Some mean ones, including steroid injections, we tend to avoid to the nail bed unless it's a very isolated item, and so you won't see those necessarily listed here. And then I think, Philip, I'll turn it to you for the IBD comorbidities.
You bet. So this time around, the GRAPPA group decided to include in their treatment recommendations associated conditions. That is, conditions that are driven by similar pathophysiology, but in a different tissue domains, such as the gut or the eye. And so we've not uncommonly see IBD occurring, either Crohn's or ulcerative colitis. And so emphasized here are the drugs that are positively beneficial for Crohn's or UC, including the monoclonal antibody constructs of the TNF inhibitors, not etanercept. And increasingly, we're learning that the IL-12/23, IL-23 JAK inhibitor classes are going to be, or currently are going to be effective and recommended as well. And for uveitis, which is a little bit tougher to sort of get our hands around, but here there's a recommendation conditionally for use of, again, the monoclonal antibody constructs of the TNF inhibitors, but also cyclosporin and methotrexate, and a conditional recommendation against of use of etanercept. So summarizing, here is what the schema looks like, and this is what you're being asked to do, is to identify which are the predominant issues that the patient is dealing with, and then choose accordingly. The one other thing that is comes out in the treatment recommendations document is thinking about background comorbidities. So, for example, if you have a patient with who is obese and happens to have fatty liver, elevated transaminases as a result of that, then be cautious about use of a drug like methotrexate or leflunomide. That just makes sense. If they have a history of significant opportunistic infection, such as, let's say, they're quantiferon gold positive, then we have to think about, well, what's the risk for use of a TNF inhibitor, for example, in that patient, and so on and so forth. So here is a checkbox that allows you to think through: should I go full speed ahead with a particular medication I'm thinking about, or show some caution based on the comorbidity that the patient has? And in particular, when I'm discussing safety with a patient, what I lead with is talking about infection, because with all of the medications, there is a slight increase in risk of serious infection, and this is something that we try to put in quantitative terms with the patient so that they can understand and put it in perspective. Sometimes they have an overly worried concern about infection. Do I have to wear a mask all the time? Well, even pre-pandemic, do I have to wear a mask all the time? And so that's why I introduce patients to the concept of events per 100 patient years, which are usually in the single digits for all of these medications. Joe, this is your baby.
My bailiwick. I'm happy to take this one. So, so this is, just to take a step back, Philip mentioned earlier that it takes a village, really, to sort of manage all of the different comorbidities and various manifestations in our psoriatic patients. And at least part of that village includes the dermatologist and the rheumatologist. There are other combinations of providers that we have seen aligned to get patients to, the most ideal care. In particular, we've seen arrangements of dermatology and or rheumatology and psychotherapy or psychiatry support. We've seen combinations with cardiovascular experts and preventative cardiologists. In fact, we have in our center a preventive cardiologist embedded within our rheumatology group, for example. So there are a variety of different combinations. Here, I think we most refer to the dermatology-rheumatology combination. And maybe 2 or 3 comments. To begin with, there is a very formalized concept of a combined clinic model. I'd say this mostly exists in academic centers where we have a dermatologist and a rheumatologist seeing patients together at the same time. We have that in our center. There are a number of other centers that do this. There are benefits and challenges to those models as listed here. You can imagine some of the benefits include really getting the patient to the right diagnosis and to therapy in a facilitated way. Patients very much like having the opportunity to ask both specialists their questions. We learn from each other. It's very collegial. It's a wonderful learning environment for trainees, et cetera, et cetera. And there's some data to support that patients get to more appropriate systemic therapy in a timely manner in those models. On the flip side, you can imagine there are many challenges, including to physician time, billing, and a variety of different administrative challenges that may put a barrier in the way. That said, we certainly have looked at these models. We have a variety of toolkits for how to consider these models with our nonprofit group we work with called Pac-Man. The last thing I'll say, though, is we don't necessarily need a formal combined clinic in order to get patients this higher level of care. And really what I think is the most beneficial and most frequently employed model is a facilitated communication model, which is really just having a dermatologist identify one or a handful of rheumatologists in the area that they can help expedite patient visits to, have a facilitated conversation with or communication with around questions that might arise. For example, knowing who the individuals in their community are that really treat psoriatic disease and are up on the literature, as it were, for the treatment, and vice versa. The rheumatologist having facilitated access to a dermatologist who can do all of those things. We also have worked on in the past different EMR templates that can facilitate gathering the data from each specialty that might help facilitate the conversation between specialists. So I think it's, on the one hand, an idealized model is a true combined clinic, but on the flip side, phone a friend, right? Get a small network built in the area that helps facilitate patients getting to the right provider in a timely manner.